Hello, my name is Luis Mora and I'm going to talk about voriconazole-induced periosteitis. First, we have a definition. Voriconazole is a second-generation triazole antifungal agent and has a broadened spectrum of activity compared to the first-generation antifungals such as fluconazole due to the attachment of an alpha-methyl group and the substitution of a fluorinated pyrimidine for a triazole ring. Voriconazole contains 3 fluoride atoms which constitute 16.3% by weight of the drug, and standard prescription of daily oral 400 mg represent consumption of 65 mg of fluoride per day.
The role of azoles. Fungi are eukaryotic organisms which possess a unique cell wall and cell membrane that can serve as targets for antifungal agents. The azole family of drugs specifically targets the fungal cell membrane. The cell membrane of fungi is similar to that of other eukaryotic cells and is composed of a lipid bilayer with proteins embedded within it. A major component of the fungal cell membrane is the presence of sterols, which are virtually absent from all prokaryotes, including bacteria. One of the essential sterols in the fungal cell membrane is ergosterol. In most fungi, it replaces the cholesterol component found in higher eukaryotic cell membranes. Ergosterol provides stability and flexibility to the fungal cell membrane. Lanosterol serves as the precursor for the formation of ergosterol. Although many enzymes are involved in the formation of ergosterol, the 14-alpha demethylase enzyme is responsible for the C14-alpha demethylation of lanosterol. It is an essential enzyme that serves as a target for azole antifungal agents. Although some azoles have an immediate effect of damaging the fungal cell membrane directly, their major mechanism of action is by binding to the cytochrome P450-mediated 14-alpha demethylase enzyme, thus inhibiting the demethylation of lanosterol and blocking the synthesis of ergosterol. In turn, this results in an accumulation of 14-alpha methylsterols and a depletion of ergosterol in the cell membrane. The lack of ergosterol in the fungal cell membrane makes it very unstable. Eventually, the cell membrane begins to break down, and the fungal organism dies.
Next, we have the applications in medicine. Triazole medications are commonly prescribed to recipients of solid organ transplantation for the prevention and treatment of fungal infections. Recently, the potential risks of long-term antifungal therapy with fluorinated triazoles have become better understood.
You know, 1 out of 5 to 1 out of 4 of the people that I meet with will never get a liver.
Mayo Clinic transplant surgeon Dr. Charles Rosen says it's a hard reality, and even more patients with failing livers would die if not for living donors.
We can take up to 70% of the liver, but not more. It grows back very quickly in both the donor and the recipient.
Occasionally, parts of lung and intestine are supplied by living donors. 4 out of 5 people on the transplant waiting list need a kidney. Dr. Rosen says kidneys from living donors function better, last longer, and can eliminate lengthy waits,
which may be 5 to 7 years in many parts of the country, during which time a patient has to be on dialysis, which may be 3 to 4 hours a session, 3 to 4 times per week.
Living donors must be at least 18, in good mental and physical health, with no alcohol or substance abuse problems. While family members often provide the best tissue match, 1 in 4 living donors are not biologically related. For the Mayo Clinic News Network, I'm Dennis Doda.
Next, we have the pros and cons. Voriconazole is a second-generation triazole antifungal agent and has broadened the spectrum of activity compared to first-generation antifungals such as fluconazole due to an attachment of an alpha-methyl group and the substitution of a fluorinated pyrimidine of triazole ring. Voriconazole contains 3 fluoride atoms, which constitute 16.3% of the drug, and standard prescription daily oral. 400 mg represents a consumption of 65 mg of fluoride per day. Next we have issue applied in Ecuador. The diagnosis of voriconazole-related peristitis most often involves the recognition of peristitis on an imaging study in the setting unexplained bone pain and long-term use of voriconazole for antifungal therapy. Elevation of serum alkaline phosphatase is an associated finding. The mainstay of effective treatment is simply to discontinue voriconazole therapy.
Welcome back. In this video we're going to be talking about a very important group of the antifungal medications. So medications are the ones that end with the suffix azole. Pretty convenient for memorization. They work by inhibiting cytochrome P450, which is an essential enzyme for the synthesis of the fungal wall. Now, indications are the most important parts. Now they're all antifungal, so they're all used to treat fungal infections. But certain medications work best for certain infections. For example, fluconazole works best for CNS infections. So remember, fluco flows into the CNS. Clotrimazole is used for cutaneous infections. Voriconazole is for invasive aspergillosis. And it causes visual disturbance. Foscanazole is the most important one, and it's used for prophylaxis of aspergillosis and candida in immunocompromised patients. Remember that it causes decrease in potassium levels and platelet count. The most important side effect of azoles is decreased testosterone levels, which result in liver dysfunction and gynecomastia. And here's a small quiz for you. So which of the following medications is contraindicated with azoles? The answer is warfarin.
And for the conclusion, voriconazole contains 3 fluoride molecules, and 5% of voriconazole is metabolized to free fluoride. Fluoride toxicity has been recognized as a cause of a bone disease called peristitis deformans since the mid-20th century. Fluoride acts on the bone by stimulating osteoblasts with corresponding increase in serum alkaline phosphatase. Although various causes of fluoride toxicity has been described, voriconazole is the most likely source of fluoride toxicity causing peristitis in this kind of patients.
Osteomyelitis is a really big word. And I actually don't use that word that often because it's kind of big and nobody can spell it and it's kind of hard to pronounce. But really what it means is infection involving a bone. So people who have infections involving bones, just like if they have infections involving other places, typically are treated with antibiotics. But there are times when antibiotics alone don't take care of the problem. So sometimes we also have to do surgery to take care of osteomyelitis. So we have to remove the part of the bone that's infected or remove the areas around the bone that might be infected. We do a number of procedures to try to get rid of the infection. Sometimes we actually put antibiotics directly in the area of the bone that's infected. We use what we call beads or spacers, and sometimes those are materials that we make right in the OR involving mixing antibiotics with other materials that are friendly to the body, and we place them in the area where the infection was. A lot of times we try to use materials that dissolve so the patient doesn't have to have another procedure to take that material out once the infection is gone. Sometimes we do have to use materials that remain intact, and sometimes they have to be removed, sometimes they get to stay in the body and don't bother anyone. A lot of times if joint replacements are involved and they're infected, we have some pretty complex procedures, sometimes even a series of procedures where we really try to get rid of the infection and then hope to replace the joint the patient has with another joint, or at least a spacer that works something like a joint, or at least something that gets them to getting back to having a joint. There are times that this can't be done, but that's always our primary objective. It's a very challenging area, and there's a lot of kind of new research going on in that area, and we're trying to stay involved with all that and bring the best that's out there back to our patients here.